not, it's not the most important thing.
Relatively close to you when you're speaking.
Okay.
That's if you can have it reasonably close to you. Like that. That's perfect. Thank you.
We're going to improvise here because if these two people haven't turned up, it's going to look terrible on the camera. So what we might do, Chakaya, is move you up here. Is that okay?
That's fine.
Actually, yeah. Well, here, so we don't have any empty space.
Spread one more.
Are you able? Are you able to focus just on the other two seats out? Yeah. Okay. So we've got a shorter press conference with many more questions.
That's okay.
Just very quickly, everybody, please put your phones off or on silent. The conference is being webcast live. Okay, we're going to start. Chakaya.
Thank you all for coming, and a very warm welcome to the official press conference on treatment. My name is Jerimiah Chakaya. I'm the current president of the union. The union, of course, is the custodian of the lung health conferences, the World Conference on Lung Health, and this is our 50th conference that is taking place here in Hyderabad. And I must say we are all very delighted that the event is attracting a lot of media attention. I'd like to say a few things before introducing my esteemed guests that are sitting with me here today. But before doing so, let me run through a little bit of housekeeping issues. This press conference is being live streamed on the conference YouTube channel, and is being archived. An archived recording will be available immediately on the conference YouTube channel. To those of you who are joining us online, please feel highly welcome. Today we will be hearing a brief remark from all our speakers, and then we will open it up to all of you for questions. We have microphones, as you can see, that are set up on either side of the room to allow you to ask questions as you line up behind those microphones if you have a question to ask. When you come up to ask a question, I will request that you say your name and you also indicate the news outlet that you come from, and then you also indicate who you are directing your question to. I would request that you keep your questions as brief and to the point as possible so that we can have as many questions as we can. Once the press conference has ended, you can approach any of our speakers for a one-on-one interview or arrange a time to do so a little later. I do know that some of the speakers are extremely busy and they need to run off to other sessions immediately after this press conference. Before we start, let me say two or so things to set the scene today. I believe many of you were at the opening ceremony yesterday, and I think you would all agree that it contains some very stunning moments, especially the performance and the speech by our TB survivor, Nandita. If you are not there in person last night to see Nandita's appearance, I would really urge you to see it. There was something so powerful to see a young woman performing a dance which she could not rehearse not so long ago because she has lost her hearing from taking TB medicines. But we know that we are, as a TB community, failing many other women like Nandita. We are failing them for many reasons, but a key one is that we have had long and inconsistent treatment regimens and high drug prices for drug-resistant TB and XDR TB and many others. But as we will hear today, this is changing. Today we are going to hear a combination of some fascinating research around treatment together with some major announcements on drugs and funding. With that, I want us to move on to our speakers. And our first speaker today will be Francesca Conradi. Francesca is a principal investigator on the next TB clinical trial of the TB Alliance phase 3 trial that is evaluating a combination of drugs for XDR TB. You have the floor, Francesca.
Thank you very much. I'm a medical doctor who qualified in South Africa, and South Africa bears an extraordinarily high burden of both TB, drug-resistant TB, and HIV. I was approached by the TB Alliance in 2013-2014 to embark on a really ambitious trial, and that trial was a combination of 3 agents. The first was bedaquiline, a drug recently registered. The second was linezolid, an old-fashioned drug that has shown to have indications for the treatment of TB. And the third was protominid, a new investigational agent. As I looked at the protocol, I thought, this is a very brave protocol, but I know the patients who get this disease. They're generally young. They're between 30 and 40 years old. Many of them are HIV co-infected, and many of them have been treated not for months, but for years on inadequate treatment. So with approval from our ethics committee, we began the trial. I have to say that the results of NICS TB surprised me. I would have been happy with a 50 to 60% cure rate in keeping with the survival rate that we were already seeing. But the results were far more impressive than that. 9 out of 10 patients who were treated on the NICS trial in South Africa were cured and had a sustained culture conversion for at least 6 months, but most of them, they're still in follow-up for up to 24 months. The regimen does have side effects, and there are studies afoot to change that, but this was a very impressive result. Not only was it a few amount of tablets, 3 medicines, which amount to, in the continuation, where in the later phase, 23 tablets a week, which may sound a lot to many of you, but we previously used 23 tablets a day. So much less tablets, but more importantly than that, the patients were treated for 6 months only, not 18 months of medicines with horrific side effects. And 9 out of 10 of these patients have gone on to be cured. Thank you for your time.
Thank you very much, Francesca. And now let's move on to our next speaker. Our next speaker is Robert Matiru. Robert Matiru is the Director of Programs at UNITAID and is here with us today to make a few very interesting and newsworthy announcements. Up to you, Robert.
Thank you, Dr. Chakaya, and thank you to all of you for coming to join us here today to hear about this news. UNITAID is happy to be investing almost $250 million in TB and MDR-TB across prevention, diagnostics, treatment, and adherence technologies. 3 new investments were recently approved, and I want to speak to you today about 2 of them. The first one is a very exciting project called Sequence and Treat, or Second Treat, which is a project that awarded close to $15 million to FIND, the Foundation for Innovative New Diagnostics, and it began implementation in October, but we'll formally launch it here at this union conference tomorrow at 12:15 in the Novotel Ballroom. And what this project is going to do is it's going to focus on increasing access to rapid, cost-effective, and fit-for-purpose drug-resistant TB diagnosis. And what it will do this is by validating and operationalizing targeted next-generation sequencing technologies. And these are essentially technologies that, through the identification of genetic mutations, can determine if any of these are associated with resistance. The grant and the project are very important and could revolutionize the drug susceptibility testing landscape because it could provide faster, safer, and more comprehensive results than we're currently getting today from culture-based drug susceptibility testing, which many of you know, you're the experts, not me, is still slow, comes with significant biosafety hazards, and there's also minimum potential for cost reductions with the current standard of care with DST. This particular project with FIND and partners will be implemented across Brazil, China, Georgia, India, and South Africa, and it will run for a period of 3 years. At the end of the day, the key things this project are going to deliver is generating clinical evidence to support WHO guidance for use in recommending next-generation sequencing for drug-resistant TB diagnosis. It will help establish what we're calling a WHO Global TB Clinical Knowledge Database. It will evaluate proof of delivery models for integrating targeted next-generation sequencing into existing diagnostic networks. And it will facilitate adoption and scale-up of recommended next-generation sequencing solutions in low and middle-income countries, the most of whom have the highest burden of MDR, TB, and TB. So a very exciting project. Really proud to have launched this project, to have signed this grant with FIND recently, and to launch it tomorrow at 12:15 in the Novotel Ballroom. A second very critical project that was also recently approved by the UNITAID board is called Ascent. And the Ascent project is a roughly $14 million project that was awarded to KNCV and its partners, the Orem Institute, London School of Hygiene and Tropical Medicine, and PATH. And what this project will do is introduce technologies to improve adherence to treatment for TB. It will increase access to more cost-effective tools and adherence technologies for this in low and middle-income countries. And this will help observe what we've long gotten used to, but with less effect than we had wanted, direct observed therapy, and enable and empower those with TB to be able to adhere better to their treatments by harnessing the promise and the potential of technology. Therefore, this project we're proud to launch, and it will run in the Ukraine, Tanzania, South Africa, Philippines, and Ethiopia, and will be a very strong complement to what we are doing with better diagnostics and with better treatments. And tomorrow we'll have another press release on the third project that will be looking to introduce better treatments for children with MDR-TB, rounding out what are 3 major new investments in this space. So I'll leave it there, and I look forward to any questions and clarifications you all have in this regard, and to launching these 2 projects tomorrow in the Novotel Ballroom at midday. Thank you.
Exciting news indeed. That's what we will really need in that space. New diagnostics, new ways of supporting people to adhere to treatment, and new regimens for drug-resistant TB in children. That's really, really great news. And now to our final speaker this afternoon. Of course, we know that one of the barriers to treating TB in the first place is getting people diagnosed. And one of the main barriers that is not talked about is the low level of males that are testing for TB. I think this is very common knowledge to many of us who manage TB. The men tend to be missing. Geoffrey Asada is a TB survivor from Thailand, and today he is with us to officially launch a new book produced by the Global Coalition of TB Activists of Men and TB. And I will ask Geoffrey to say a few words, and I've also eventually show you the book that is being launched today. Thank you.
Sure, thank you so much. Hello again, everybody. My name is Geoffrey Asada. I'm with the Global Coalition of TB Activists. We were established in 2013, and we now have around 300 members globally. It's really very exciting that we see a lot of progress in terms of implementation, in terms of the programming and financing also in this conference. But at the same time, it's also really very important to document the experiences of people with TB and also those affected by tuberculosis in order for us to have a better understanding of not only the experience but also the barriers in helping us design what would be a person-centered approach to tuberculosis. So GCTA, our network has started documenting some of these different stories from different populations. Early last year, we started documenting stories among women with tuberculosis, and we did released a book, Women and Stigma, focusing on the experiences of stigma and experience of discrimination among women. And then after that, we did also publish Childhood and Tuberculosis, which focused on families and also the experience of children with tuberculosis and the families affected by tuberculosis. For this year, we are very happy to announce the launch of Men and Stigma. Given that in 2017, almost around 6 million adult men were infected by tuberculosis. This is even higher compared to the women who were diagnosed only around 3.2 million worldwide. So it's really very important to capture these experiences, given that we know so very little about the experiences of men, given the culture of the macho culture that men are experiencing, the level of disclosure and the confidence that they seek whenever they experience different diseases, including tuberculosis. So it's very important for us to document such. And may I show you the book? This is the official book of Men and Stigma. This contains around 8 stories from all around the region. So we were able to document 4 stories coming from Asia, including Afghanistan, Cambodia, Philippines, and also Tajikistan. We do have 2 from Africa, from Burundi and Gabon, and also 2 from Peru and Mexico. So I'm sure that there's going to be stigma-related sessions around this conference this week, but if you find time while walking or having lunch or something, just what I did just early today, find time to read through and have a more thorough understanding of the experiences of people with TB. My story is also in this book, so I would appreciate if you find time to really look at it. Thanks.
Thank you, Geoffrey. And before we open it up for question and answer, I would want to announce that we are also launching this book that many of you in the room are familiar with, the Union's Orange Guide on TB care and prevention. This is a comprehensive, very concise, though comprehensive but concise book that outlines all the procedures and processes that happen in the management and care of people with TB, and also all the programmatic issues that any TB program would want to do. It's very concise, very well done, and I would suggest that each and every one of us who is involved in the war against TB should have a copy of this. It's available online. So this would give you, if you want, you could come and pick up copies of this. It's available online. You can download copies of the Orange Guide for TB care and prevention. Now it's time for our questions, questions that you have. Like I said before, we have microphones on the side. Please line up to ask your question. And please indicate your name and the news media outlet that you represent. And I see you there, so please go ahead.
Thank you very much. It's Amy Green from South Africa, freelance journalist. My question is for Dr. Conradi. Thank you so much for reporting on the next TB trial. I'd just like to know what happens now. We've got this great cure rates, 9 out of 10. Is it being extended programmatically in South Africa and across the world, and is there a timeline?
So I'll answer the last question first. There's not yet a timeline, but it is very important that we get these medicines out as quickly as possible. The BPAL regimen has been registered by the Food and Drug Administration. It was registered on the 14th of August. It's been submitted to a number of regulatory authorities for registration. The Indian registration was submitted in July, even prior to FDA approval. It's been submitted to the South African regulatory authority, to SAHPRA, it has been or will be submitted in the next couple of days. But there are two processes that we need to bear in mind. The first is that we want this regimen to be registered as broadly as possible. But in the meantime, a 9 out of 10 success rate means that we need to try and get these medicines safely to the individuals who need them as quickly as possible. A number of countries have embarked on a clinical access or compassionate access program, which is kind of a hybrid between a clinical trial and full programmatic access to get people to take this medicine who need it as quickly as possible. Thanks.
Thank you, Francesca. Are there other questions?
Hi, my name is Sai Gopal. I am from Telangana Today, an English daily in Hyderabad. My question is to Mr. Robert. He mentioned about the next generation NGS screening diagnostic technique in India. I mean, they're going to launch in India. Any details, sir, where you are going to launch, and how are the patients going to benefit from this facility, sir?
Please go ahead, Robert.
Thank you. I have the advantage of having the Chief Executive Officer Find in the room, and maybe she'd be better placed to answer that question than me. Okay, a member of the Find team is going to answer.
Thank you. Thank you. Please go to the microphone, say your name, say what you do in Find before you answer the question.
All right. Thank you for the question. My name is Anita Suresh. I'm head of sequencing at Find. And just to answer your question specifically on India, the work under this project will be first a clinical trial that will be at a couple of sites that we'll do in India to evaluate the use of next-gen sequencing. But in addition, we will also be working to see how the delivery model will be for actually using sequencing so that patients, at the end of the day, patients can benefit from it, and how cost-effectively and efficiently it can be rolled out to the program. So those will be the two ways. So during the course of the project itself will be mainly the clinical trial for generating the evidence, and also proof of delivery, and also working with the TB program to really see how best to scale it up and which would be the sites and where we start rolling this out so that programmatically and widely patients get access to this diagnostic as soon as possible.
Thank you. Much better than I could have answered. Thank you.
Thank you. Let's go to the next question. Please say your name, your media outlet, and the person you are directing your question to.
Jackie Thornton, The Lancet. This is a question for Robert Materu. Robert, you talked about the adherence tools and about developing those to make things easier for patients to take these drugs. Can you speculate or to give you some comment on what kind of adherence tools you might be talking about?
Absolutely, happy to. So the challenge we're facing today is that certain smart tools, for example, let's say smart pill boxes, which do exist, and they help patients by measuring every time a pill is taken from the box as they take their daily treatment. The problem with such tools is not the tool itself, it's that they haven't been rolled out widely, they haven't been adopted widely, the value hasn't necessarily been demonstrated routinely and at scale. And one important aspect of this project will be to do just that, take existing tools and ensure that they're actually delivering the value that they can deliver and measure the cost effectiveness and impact that they can bring. But there's other innovations that the project will bring that might be, for example, harnessing the benefits of mobile telephony, using smart apps on phones that, and doesn't even just require a smartphone. It could just require a regular phone on which an app can be run that can help patients not just be reminded when to take their treatment, but also then link to follow-up and healthcare providers, counseling, advice, things that, again, we need to mainstream, position, demonstrate are cost effective, and then position for scale. At the end of the day, KNCV and Unity share the philosophy that whatever innovations we bring, if they aren't scaled, we won't get the impact we're seeking. There's other tools that are being looked at that might be able to harness the use of computers, television, and so on, that will help, again, accessible things that may exist on a day-to-day basis that can be harnessed for the benefit of supporting adherence. What is critical, I think, and I didn't say it earlier, is the empowering effect that this can bring, because it enables the patient to have a support, a tool that helps empower them to take their medicine without having to go to a particular center or having to report to a particular person. It's more empowering and more independent for them to have these tools at their support to support them take their medicine. So those are just some examples. And certainly after this press conference, we have the head of KNCV here who can articulate in even more detail some of the examples we'll be using. So Kitty is in the room, and she'll be available as well. Thank you.
Do you have any follow-up question? So now that, Kitty, you've been mentioned several times in this room, would you want to say something about this project? If you do, you need to go to the microphone and say your name. All right, okay, that's good. Thank you, Kitty. Thank you. Thank you. I can see you're beginning to think about passing the baton to the next fellow.
Yeah, thank you very much. My name is Christian van Kanthout. I'm the project director of the Ascend project. And it was a very good question, and I can only add to what Robert was saying. We use existing tools that are already there, but might not be used at the full scale, at their full potential to support tuberculosis patients. So those are smart pillboxes that help patients to engage with their treatment, to help healthcare workers stay in contact with their patients, but also other tools like medication sleeves and interactions with very simple to use phones, so that they can be scaled up to and reach as many patients as possible. So this is the whole philosophy. And what we do under the Ascend project, we implement these technologies and these interventions in 5 different countries with all different characteristics, different ways of how tuberculosis care is being provided right now. At the same time, rigorously evaluate these technologies, their effectiveness, but also their acceptability. The acceptability of patients, but also the acceptability of healthcare providers. How can they use the technologies at best, and how can we adapt and customize these interventions so that patients can be supported to the best extent. And thirdly, after implementation and evidence generation, what are the mechanisms needed for scale-up? What are the product economics and the manufacturing considerations so that we can bring these technologies to the lowest price possible and eventually reach all TB patients in the world with these technologies? And I'm happy to answer any other questions after the meeting.
Thank you. Thank you very much. Are there any other questions? Okay. Then I think we will bring this to an end. You've heard about the exciting things that are happening. The next trial results showing very good results, very good outcomes in a group of patients that we've had difficulties with in the TB world treating, and the potential that we can cure many of these patients, which I think is really a great thing. But to cure people, you have to diagnose those patients. If you don't diagnose them, or if you don't diagnose them early enough, then even if you treat them to cure them, you will get bacteriological cure, but people end up having problems for the rest of their lives. So I think we're very happy to hear that, in fact, there are new diagnostics. So that goes hand in hand with what is happening here. We have better treatment, and we also have better diagnostics. And in addition to that, we have better ways of helping people remain adherent to treatment. I think all these things fit very nicely together. And then we have documented experiences here on how to find difficult people who we tend not to find easily, the men. And we also have a guide on how programs can be delivered at country level. So all this fits very nicely together. I want to thank the speakers today for being as very eloquent, extremely eloquent fellows. I'd like to be close to them all the time, listening to them, because they're really, really eloquent and have presented the issues very, very clearly to us. And I want to thank all of you for having found time to be in this press conference. Thank you very much, and enjoy the rest of the conference.